Our next presenter is, this is the most fun part of this symposium now, so we're gonna get to chat with Drs. De Silva about their surgeries and their approaches. So our first speaker is actually Dr. Carley Bright, who is our Senior Pediatric Cardiology Fellow at the Heart Institute here in Pittsburgh and the Chief Clinical Fellow. She will present some cases, and then Drs. Luciana and Jose De Silva will comment on these cases. So without any further delay, welcome Dr. Bright.
Thank you so much. Thank you, Dr. Al-Saeed. I'm really excited today to share three really interesting cases in which the De Silvas were successfully able to use the cone procedure to repair these patients' tricuspid valves. After the second and third case that I share, the De Silvas are going to follow up with some insight into surgical technique for those specific cases. So the first case that I'm going to talk about is actually the patient that we just heard from, and it's a cone procedure after tricuspid valve replacement. Following that, I'll talk about cone after Starnes procedure, and then cone after Fontan. So the first case is, like I said, we just heard from her. It's a 47-year-old female with Ebstein's anomaly of the tricuspid valve. She went through her kind of long surgical history, and just to briefly review it, she had a tricuspid valve repair in the first year of life, had an ASD closure at 3 years of age, then underwent her first mechanical valve placement in the tricuspid valve position when she was 24 years of age. At that time, she also had a pulmonary valve replacement with a cadaveric valve, and then following that, had to have a second mechanical valve placed in the tricuspid valve position, and at that time also had a maze procedure and placement of epicardial pacing wires. Despite all that, she still developed tricuspid valve stenosis that was severe and moderate pulmonary valve insufficiency, and as she mentioned, had recurrent atrial arrhythmias and right heart failure. So her cardiologist referred her to the De Silva Center for consideration of a cone procedure, and this was her preoperative transthoracic echocardiogram, so you can see the flow acceleration at the level of that mechanical tricuspid valve, and her gradient was severe. It ranged from 12 to 16 millimeters of mercury across that tricuspid valve. And then this is looking at her pulmonary valve, which she did have moderate insufficiency of that pulmonary valve in the preoperative period. We did perform fluoroscopy of her mechanical valve to get a better sense of the function, and you can see that there is decreased mobility, particularly of that posterior superior leaflet, and just very abnormal opening of that mechanical valve. So given that she was an adult, we did not have access to her neonatal imaging, so she underwent CT to evaluate the tricuspid valve tissue underneath that mechanical valve, and the De Silvas felt that there was adequate tricuspid valve tissue to proceed with cone repair. So she came to our center and had explantation of her mechanical tricuspid valve. She had a cone repair of her tricuspid valve, and she also had a pulmonary valve replacement with a mosaic pulmonary valve. And this was her postoperative transthoracic echo, which shows a beautiful repair with really just a trivial gradient across that valve and no significant insufficiency. And then this was her pulmonary valve, which is now competent and also with no stenosis. So that was a beautiful result from that case for a woman who had gone through several surgeries prior and was able to have successful cone procedure on her tricuspid valve. The second case I wanted to share was a toddler who had a cone procedure after Starnes. So she had severe Ebstein's anomaly of the tricuspid valve. Hers was actually postnatally diagnosed. She was very sick in the neonatal period with respiratory failure, severe hypoxia. She required mechanical ventilation, nitric oxide therapy, and had evidence of a circular shunt. So she underwent a Starnes procedure in order to save her life at her home institution with an atrial septectomy, and then oversewing of her main pulmonary artery and placement of a modified BTT shunt. She did well after that procedure and subsequently had a bidirectional Glenn procedure with takedown of her shunt at 8 months of age. She had mild left ventricular systolic dysfunction, but was overall clinically doing well, and her team kind of decided to refer her to the De Silva Center for consideration of a cone procedure versus a Fontan procedure. So as many other people have already mentioned, when we're looking at these patients who have had prior interventions, it's very important if possible, for us to be able to review their newborn imaging. And in her case, we were able to review her newborn echocardiogram. And you can see here the Ebstein's anomaly, the tricuspid valve, with that large sail-like anterior leaflet, and here with color, the moderate regurgitation at that time. This is looking at her pulmonary valve in the neonatal period. So she had a good-sized pulmonary valve, actually, but you can see here, under those physiologic conditions, the pulmonary valve leaflets really aren't opening, and then she had moderate regurgitation, setting her up for a circular shunt. This is just another view of her tricuspid valve, which is rotated into the outflow tract, and again with moderate insufficiency. So she had her Starnes procedure and subsequently her Glenn, and then came to us for cardiac catheterization. So this is a nice angiogram in the right ventricle, and you can see that the right ventricle is small, decompressed. There's that flow back into the right atrium through the Starnes fenestration. And then most interestingly for her here, the pulmonary valve, you can see those leaflets are still intact. So on reviewing this, the De Silvas felt that they could still use that pulmonary valve during her repair. She had preoperative MRI assessment, and similar to some of the patients that Dr. Al-Saeed showed, you can see that right ventricle is small, decompressed. You can see the flow across the Starnes fenestration. And then she also had a nice 3D reconstruction showing her Glenn, which was unobstructed into the branch pulmonary arteries, which were of good size. And then you can see here, this is where the main pulmonary artery was oversewn, and the right ventricle, again, you can see is small and decompressed. This was her preoperative transesophageal echocardiogram with a similar appearance of that right ventricle. It's decompressed, and the function is severely diminished in the setting of that Starnes patch. And then with color, you can see the flow across the Starnes patch fenestration. So she underwent a Starnes patch takedown, the De Silva cone repair, a fenestrated ASD closure, and she had a valve-sparing pulmonary valve repair. And this was her post-operative transthoracic echocardiogram, which is beautiful. You can see the surgical changes to that tricuspid valve with the cone procedure, and was only a trivial gradient across it and really just trivial insufficiency there. And then this is her native pulmonary valve, and there was no stenosis and just mild insufficiency. So I want to invite up Dr. De Fonseca De Silva to talk about the surgical technique for this specific type of procedure of cone after Starnes.